Come on, start. There we go. All right. So this is going to seem very redundant because it's going to have a lot of the same information that you saw from your lecture review guide, but it's also going to have images which are going to be different from the ones that you saw during lecture that are going to be correlated to your lab textbook. So I'm probably going to focus pretty heavily on those and gloss through the actual text material that you've already seen unless you have any questions on it. But I will start by saying that Lab Exam 2 is going to be comprised very similarly to Lab Exam 1 and to what we've seen in 151, in that it's going to start off with a very small subsection that are going to be multiple choice, that'll kind of warm you up kind of questions that talk about structure and function of whatever the topic is. And they're going to be multiple choice, true, false, etc. And then the rest of it, which is going to be the majority of it, I think about 60% of it or so, maybe 70, 65%, is going to be comprised of the images. And you're going to get those images directly from the images that are shown in this file here that are found in your lab manual. And they're just going to be unlabeled or delabeled, I guess. So they'll just be blank with A, B, C, D, just like you'd seen before. Okay? Before I hop in, does anybody have any questions? I'm going to take that as a no. Okay, all right, so the first section is endocrine, and I do want to point out that somehow in the actual text of the syllabus, I have misspoken. I said that, or I guess in the course schedule, I said that we would be starting on Unit 34 or Exercise 34 for this exam, and that's not true. We're starting on Exercise 33. It's just that 33 and 38 got kind of shuffled separately a little bit in advance, or a little bit later on, and I must have missed that when I was looking at how we were setting it up. But you are tested on Exercise 33, so the endocrine system. And all of the questions that are going to be in that true, false, multiple choice section are all going to be found in the information that you can find here that talks about the different types of glands, right? Exocrine versus endocrine glands, basically whether or not they're going to be carrying things into the blood supply, which is like the exocrines, or if they're going to be secreted into ducts, which are going to end it to the target site. We talked about hormones and the type of receptors that allow hormones to be able to send information inside. And we also talked about how we can up or down regulate our response to the hormones based on their concentration. 3 major types of circulation, right? Autocrine and paracrine. I thought there were 2. It looks like there's no. Sorry, I thought there were 3. But yeah, autocrine and paracrine. So basically, whether they're going to be acting, endocrine, autocrine, and paracrine. There are 3. So the ones that are circulating are endocrines. The ones that act on neighboring cells are paracrines, and if they act nearby, that's or on the same cell, sorry, that's going to be autocrine. So this is when we were talking about whether or not you're able to get your signal to a large audience or just like a small newspaper. Hormones are split up into water-soluble and lipid-soluble, basically whether or not they're going to interact well or with water or with lipids. And that's going to determine whether or not they're going to be able to go into aqueous solution or whether or not they're going to embed in the membrane, for example, like lipid-soluble hormones, etc. And how they're transported in the blood as well. Like the water-soluble hormones can circulate without being attached to anything, but the lipid-soluble hormones have to be transport proteins to be carried in the blood supply. Water-soluble hormones and lipid-soluble hormones work a little bit differently in that lipid-soluble hormones can actually pass through and bind to and activate receptors within the cells, and they can actually get inside and alter gene expression to change the concentration of proteins that are formed or up or down regulate the expression of certain proteins. Whereas water-soluble hormones are going to attach to the cell membrane by activating plasma membrane receptors, and that's going to send off an intracellular cascade. It's the equivalent of like knocking on the door and telling the butler to go tell the bad news instead of coming in yourself. And so it's going to set off a series of events inside, including the second messenger, to be able to get to wherever the response is inside the cell. Yes, I've talked about this all pretty extensively when we talked about it in class, which I think was a while ago. So hormones are controlled by the nervous system, the chemical changes in the blood, and their interaction with other hormones. So some of them have an additive effect, and some of them have a kind of opposite effect. So For example, this was when I said that if someone came and knocked on your door and said, I'm not sure if there's a fire, and then a second person came and knocked on your door and said, never mind, it's just my barbecue, you'd be like, okay, never mind, I'd ignore the first person. But if the second person knocked on your door and said, holy crap, it's a fire, please evacuate, you would amplify the effect of the first person having told you that there might be a fire. Oftentimes, hormonal secretion is regulated by negative feedback systems. In fact, almost everything is regulated by negative feedback systems. And the hypothalamus and the pituitary gland are going to be the major expression for your endocrine system. The hypothalamus is going to link your nervous system and your endocrine system. And the hypothalamus and the pituitary gland are going to regulate growth, development, metabolism, and homeostasis. I don't ask you where it's paired or where it's found. We do talk about the hypothalamic portal system, which is basically how we're getting blood to the anterior pituitary coming from the hypophyseal arteries and the hypothalamus. Let's see. We did also talk about the different types of cells in the anterior pituitary. Mainly, we talked about the types of hormones that they are going to produce, namely HGH, TSH, FSH, prolactin, and ACTH. We also talked about what they do, so if you want to go and refresh yourself on that, that's going to be table 18.3 in your text, but I'm not going to go through those right now because we have a 70-page document. Let's see. We also talked about HGH, which is human growth hormone, and also IGF, which is insulin-like growth factors. These are both going to stimulate growth of the body and regulate metabolism. So HGH is going to act on the tissues by creating IGFs. Then IGFs are going to stimulate body growth. And there are many things that can stimulate or inhibit HGH production. Thyroid stimulating hormone is going to come from this, going to stimulate the production of thyroid hormones from the thyroid gland, and is controlled by a thyrotropin releasing hormone. Follicle stimulating hormone, or FSH, is going to be involved in the creation of the follicles in the female reproductive tract, as well as secretion of estrogen in the ovaries. And in the male, it also plays a role in the production of sperm in the testes. LH is also involved in the female reproductive cycle. That's luteinizing hormone, and we'll talk about that when we get to reproduction and development, which is still coming up in this semester. But LH is going to help stimulate the secretion of estrogen in order to cause ovulation, and also is going to create the corpus luteum and then secrete progesterone. And in males, it's going to help stimulate testosterone secreted from the interstitial cells of the testes. Prolactin is going to initiate milk secretion from the mammary glands. Adrenocorticotropic hormone is going to produce hormones that are called glucocorticoids. Those are found in the adrenal glands, which are found just above the kidneys, right? And then MSH, melanocyte-stimulating hormone, is going to increase pigmentation in the skin. And again, if you need to summarize or more detail, you can see table 18.4. We also talked about the posterior pituitaries, which is not going to synthesize hormones, just like the anterior pituitary. However, it does store and release two hormones, and these are both hormones that are going to be created by the hypothalamus and secreted. So the hypothalamus has neurosecretory cells that are going to create and secrete these two hormones, and they're going to connect it to the posterior pituitary via the hypophyseal tract. All right, so the hypothalamus makes and stores these two hormones in the posterior pituitary. It's called oxytocin, an antidiuretic hormone, or ADH. Oxytocin is the love hormone. It's going to be involved in uterine contraction and milk letdown. And it's also going to be something that allows you to feel like you love your baby. It's going to help when you're nursing your baby or being in contact with your baby. And additionally, it's going to help promote those extrauterine contractions after delivery that'll help expel the placenta. And ADH is going to help stimulate water resorption by the kidneys and constriction of the arteries. And the idea of ADH is to be able to decrease the urine volume so you can conserve as much body water as possible. So it's an antidiuretic, essentially, and it's controlled almost entirely by the osmotic pressure of the blood. And we talked about that as well, and that has to do with the concentration of solutes inside the blood supply, so how aqueous the blood is. And namely, we said that the concentration of salt means that water will directly follow. So if you have something that has high salt, water is going to go across the membrane towards the concentration of salts. And we talked about why. If you need any help with that, we can go back to figure 18.9, talking about how the blood osmotic pressure regulates that. But again, a lot of this is just going to be for the true or false section. Mainly what we should be focusing on is going to be our images. The thyroid gland is another setup from the endocrine system. It's found below the larynx, has two lobes, the right and the left. Thyroid follicles have follicular cells that secrete T4 and T3, and then also parafollicular cells which surround that secrete calcitonin. We talked about the role of calcitonin as well as T3 and T4, but basically these are going to be involved in a lot of things. Let's see if it tells you here. Okay, so we'll talk about it in a second. So then I'll move on. So these thyroid hormones are all going to be synthesized inside this inside the follicle, and it's made into this molecule called thyroglobin, or TGB, and that's going to be transported in the blood afterwards. Certain proteins called plasma proteins in the blood, including one called TBG, so it's a kind of the opposite of TGB. So that's called thyroxine binding globulin, and that's going to be the transport molecule in the blood. And we talked about all of the different stages of this, and I told you not to focus on it too much, just to kind of understand that there were these major steps, including iodine trapping, the creation of thyroglobin, then we had to oxidize and iodinize, and then couple T1 and T2 that end up getting kind of brought in. Remember, we had the image where they reached out and had pinocytosis and digested them, and then that is going to cause them to create the thyroid hormones that gets transported through the blood. And again, if you need a refresher, you can look at figure 1811. This is all figures that are here are all cited to your textbook, not to your lab textbook. But the images that you'll see that are going to come up on the lab exam are going to come from your lab textbook. All right, so thyroid hormones are involved in metabolism, growth and development, and calcitonin is going to be involved in blood calcium levels, which indirectly is involved in your propensity for something like osteoporosis. The parathyroid glands are going to be found just inside the thyroid, and they have cells that are principal cells that make PTH, or parathyroid hormone, and then specialty cells called oxyphil cells whose function is not yet known. But PTH, we do know what it does. It's going to regulate calcium homeostasis and phosphate homeostasis by increasing the calcium level and decreasing the phosphate levels in the blood. And we talked about how that worked pretty extensively, but if you want to see that negative feedback loop, you can again go refer yourself to 1814. Adrenal glands, again, still endocrine system. They're found just above the kidneys. They have just like several other things, like we'll see throughout your anatomy textbook. They have an outer cortex and an inner medulla. In the cortex, we have three major zones that are going to secrete different hormones. Outer zone is the zona glomerulosa, secretes mineralocorticoids. Middle zone, zona fasciculata, secretes glucocorticoids, and that inner zone is the zona reticularis, secreting androgens. And yes, you do need to know which hormones are secreted at which of these levels. And the bare minimum, you should know from the outside working your way in which zone is which. Aldosterone is a good example of a mineralocorticoid, which are going to be involved in sodium and water balance, and also help with potassium resorption, which helps to regulate the levels of sodium and potassium within the body, and that's going to be controlled by the renin-angiotensin pathway, and also the amount of potassium that is in the blood. And if you need more reference for the renin-angiotensin pathway, we've gone over it several times, but you can find it again in figure 1816. Moving on. Okay, so glucocorticoids are going to help break down proteins, create glucose, break down lipids, help with stress resistance. They also have anti-inflammatory effect, but however, they are going to help reduce the immune response. They are secreted by CRH, corticotropin releasing hormone, and ACTH, both from the anterior pituitary. And we talked about the anterior pituitary a little bit earlier. Let's see. Also, the adrenal cortex is going to secrete androgens, which are going to have minimal effects in the male because testosterone at this point is going to be pretty strong, and so we're not going to need DHEA anymore in terms of androgen response. But in the female, it's going to be the main source of androgens coming from the adrenal cortex, and so that's going to be more pronounced in terms of the effects that they have on the female. The adrenal medulla is going to have hormone-producing cells. Those are called chromaffin cells. You may have heard of those previously when we were talking about fight or flight versus rest and digest. But these guys are going to have they're going to surround areas that are filled with blood, so large sinus pools of blood. And we have medullary secretions inside here, namely epinephrine and norepinephrine. These are going to be your adrenaline, and these are going to produce the sympathetic responses, are going to be produced in response to sympathetic pathways. They're going to have effects that are going to be secreted into the bloodstream. So they're going to be released under stress from the autonomic nervous system, and they help the body resist stress a little bit over a short duration, but they're not going to be good for you to be secreting on longer terms or longer frames of time. Let's see. Okay, so let's talk about the pancreas. The pancreas also is part of the endocrine system. It's a long, flat organ, and we talked about it with digestion quite extensively. It's classified as both an endocrine and an exocrine gland because it's going to secrete things both locally and on a larger scale. Histologically, it's going to have the pancreatic islets, which they're called islets of Langerhans because he's the one that figured them out, and acini cells, which are cells that are going to be exocrine cells that produce enzymes. In the pancreatic islets, we have alpha, beta, delta, and F cells. All of these are going to be involved in, many of these are going to be involved in blood glucose levels, and they're going to all interrelatedly regulate each other. So alpha cells are going to secrete glucagon, and glucagon is going to increase your blood glucose levels. And beta cells secrete insulin, which decreases your blood glucose levels. And then delta cells secrete somatostatin, which inhibits both insulin and glucagon secretion. So delta regulates both alpha and beta. And then F cells secrete something called pancreatic polypeptide, which regulates the release of all of the pancreatic digestive enzymes. And again, that's going to be involved in blood sugar regulation as well, because we're going to be using these digestive enzymes to start digesting sugars during the digestive period, right, when they're in the intestines. And then absorbing that would end up increasing your blood sugar level. And we talked about how both glucagon and insulin secretion have negative feedback loops on themselves. And if you need more refresher on that, that's 1819. Additionally, the ovaries and the testes are going to be part of the endocrine system. These are going to be found in the pelvic cavity for the female and descended from the pelvic cavity for the male. And they're going to produce sex hormones, namely estrogens and progesterone for the ovaries. And then the testes, of course, are going to provide primarily testosterone, but other androgens as well. All right, so let's move on to the pineal gland, because we'll talk more extensively about the testes and the ovaries when we get to reproductive tract. The pineal gland is going to be found inside the brain, attached to the roof of the third ventricle of the brain. And it has secretory cells that are called parenchymal cells. These guys are actually, their specific name is called pinealocytes, neuroglial cells, and specialty postganglionic sympathetic fibers. And these guys are going to be responsible for the secretion of melatonin, which is going to help us with our circadian rhythm, essentially. So the diurnal rhythm that's linked to dark light cycle, which is what tells us when to be awake and when to be asleep. The thymus is going to be responsible for immunity. We talked about that extensively when we talked about the immune system. And also the thymosin, thymic humoral factor, thymic factor, and thymopoietin are all going to be involved in the proliferation and maturation of T cells, which are, again, involved in immunity. They're a specialty type of white blood cell that are kind of like your soldier cells that go out with receptors on their surface and target cells for destruction that are non-self or have been targeted as infected. All right, so other endocrine tissues and organs. Hormones from other endocrine organs can be found in 1811. I'm going to skip through a lot of this. So growth factors are going to be factors that are going to induce growth of certain tissues. So epidermal growth factor will induce the growth of epidermal cells. Platelet-derived growth factor will cause more platelets to grow. Fibroblast growth factor will cause more fibroblast growth, etc. Tumor angiogenic factors, or any angiogenic factor, is going to cause the growth of blood vessels. And we talked about stress response. All right. I'm not going to talk about development or aging and disorders. So for the blood, I don't have the figures specifically, but any of the content is fair game. So don't expect me to talk about or ask you to do any of the blood typing, but you can expect that I will ask you blood typing questions in detail. So that means that you need to understand what is going to react with what and how we determine what blood type is what. So please make sure that you review the blood lab and the blood outline, which is going to be found in the announcement section, such that you know what an agglutination reaction looks like, for example. So if I show you an image, which I'm not actually going to, I'll just describe it, but you'll be able to tell me if I get a reaction with this antibody, whether or not I have what blood type. Okay, and that includes the Rh factors as well. So expect blood typing questions to come up in detail. So for blood, we were talking about, and for the endocrine system, there's not going to be, I don't think, very many images. I don't think we used images from the endocrine system. Just kind of have a couple questions in there. So we talked about blood and the function of blood. I feel like we've talked about this fairly extensively since I just tested on it, so I'm going to kind of gloss over it. But basically, it's going to be a fluid inside the body that's involved in gas exchange and nutrient and waste delivery / disposal. It's a connective tissue that is going to interact directly with the interstitial fluid, which interacts directly, well, indirectly through the plasma membrane with the cell fluid or the cytoplasm. What does blood do? It helps regulate pH, body temperature, and water content of cells. And also, it's going to help it clots, so it prevents its own loss, and it helps combat toxins and microbes through phagocytosis. Those are those specialty white blood cells. It's going to be mainly plasma, but a pretty close second is formed elements. Formed elements can include your white blood cells, your red blood cells, and your platelets. Let's see, the formed elements, again, it's going to include white blood cells, red blood cells, and platelets, thrombocytes. All right, so in terms of the blood cell formation, we hit this up pretty heavily when we were talking about it in class. We had a nice little, what should we call it, diagram that shows you the different types of blood cells. And basically these guys are going to be coming from a pluripotent stem cell line, namely the myeloid stem cells and the lymphoid stem cells. And the myeloid stem cells are going to give rise to the red blood cells, platelets, and all white blood cells except for lymphocytes. And the lymphoid stem cell line gives rise to all of the lymphocytes. And so myeloid stem cells are going to turn into specialty progenitor cells or precursor cells, which are called blast cells. They become the formed elements of blood. Let's see. And then lymphoid stem cells are going to turn into B lymphocytes and T lymphocytes as well. And hemopoiesis / hematopoiesis, these are going to be the creation of new, it's all stimulated by hematopoietic growth factors, so it's going to be the creation of new blood. And that's going to stimulate the differentiation and proliferation of blood cells. We have specialty factors including erythropoietin, thrombopoietin, and cytokines that are going to help increase, respectively, red blood cells, platelets, and white blood cells. And we use bone marrow for disease. Let's see. Red blood cells are they have no nucleus, they're anucleatic, they're biconcave, and they have hemoglobin. So hemoglobin is going to be the major molecule that we are going to be concerned about in terms of the red blood cells, in that it's able to carry both oxygen and carbon dioxide, mainly oxygen, and that's going to allow us to deliver and distribute oxygen to the tissues. About 33% of the red blood cells is going to be comprised of these hemoglobin molecules. Again, hemoglobin functions to transport oxygen and carbon dioxide, although carbon dioxide is also found in bicarbonate in the bloodstream. Let's see, hemoglobin can also bind nitrous oxide and release nitrous oxide, and nitrous oxide is involved in vasodilation. So if we end up with a release of nitrous oxide, we can increase our blood flow and circulation and enhance delivery of oxygen to that particular area. So that's actually going to be good for getting circulation to that tissue. Red blood cells live about 120 days, then they eventually die off. They're going to get worn out and be phagocytosed by macrophages, and certain things are going to get recycled, like the hemoglobin, etc. And eventually they're going to get destroyed by the spleen. The creation of erythrocytes, or red blood cells, is going to be erythropoiesis. Erythropoiesis happens in the red bone marrow, and that's stimulated by hypoxia. So if we have low oxygen conditions, it's going to stimulate the creation of more red blood cells. This is why people who move to areas like Colorado, where it's really high up in the mountains, and they start getting kind of sick for a little bit, they'll get altitude sickness. But after a couple of weeks, their body responds to that constant low oxygen conditions or hypoxic conditions, and they end up creating more and more red blood cells. So average reticulocyte count is going to be really helpful for indicating whether or not you have anemia and the rate of erythropoiesis, or creation of new red blood cells. Major types of white blood cells are going to be grouped into two categories, whether they're granular or agranular. If they are granular, that's going to include eosinophils, basophils, neutrophils. And again, this is all just basically how it stains. Agranular leukocytes do not have cytoplasmic granules. And that's going to include lymphocytes and monocytes. So most leukocytes are going to have surface proteins that are called major histocompatibility antigens, or MHC complexes. And they're unique for each individual and can be used to identify the tissue. So it doesn't just say the tissue type, it says that it came from a particular individual. And again, this plays into why someone who gets an organ transplant might need immunorejection drugs for the rest of their lives. Because that organ is going to have different histocompatibility antigens, which means that they might be detected as non-self by the immune system. White blood cells don't live as long as red blood cells, only a couple hours to a few days. We have about 5,000 to 10,000 per millimeter, which would be, millimeter of your blood. Let's see. And if we have a high amount of white blood cells, that's going to be called leukocytosis. If we have a low amount, that's leukopenia. And basically, these guys work as your immune system to help combat inflammation and infection. They're going to go ahead and get out of the bloodstream by a process called emigration when there's a site of inflammation or injury nearby. And sometimes, so they're attracted by what's called chemotaxis, and sometimes they're active in phagocytosis too, which is actually engulfing and ingesting the foreign invader. Now, the different white blood cells are going to combat inflammation in different ways. So neutrophils can be and macrophages, which can either be wandering or fixed. That means that they can be localized or they can be in circulation. And they can ingest foreign invaders through phagocytosis. Eosinophils are going to combat histamine and be involved in antibody-antigen complexes and in combating parasitic worms. Basophils can be involved in the allergic reactions as well. They're going to liberate heparin, histamine, and serotonin in allergic reactions, so that's going to intensify the inflammatory response. So basically, basophils are going to work to do the opposite of eosinophils. Eosinophils are basically going to be telling basophils to chill your roll, right? Because these guys are going to be releasing histamine, and these guys are going to be combating the effects of histamine. We also have B lymphocytes and T lymphocytes, which at this point you should know like the back of your hand, which are going to be involved in the immune response. They're going to be created in the bone marrow and in the thymus, respectively. Platelets are going to be developed from megakaryoblast. Megakaryoblast become megakaryocytes, which fragment into tons of platelets, thousands of platelets, and each of these platelets are going to be called a thrombocyte. They're enclosed in a cell membrane, and they have a specific function. Platelets don't live very long, about 5 to 9 days. They're going to be destroyed by macrophages. Again, that's mainly going to be the spleen, but also the liver. But their main role is going to be staving off blood loss by forming that platelet plug if we end up with injury, so that we're going to be able to repair that area without having a ton of blood loss in that region. So blood count is something that you guys are going to be learning about. You're probably going to be taking blood draws if you're, well, it depends, I guess, on what you guys are going to end up doing with nursing, but more than likely at some point you'll be taking blood draws. And when we do a blood draw, we're looking at several things, but a general blood count is going to be screening for the concentration of red blood cells, white blood cells, and platelets, as well as hematocrit and differential white blood cell counts. So the amounts of how many of the different types of white blood cells can determine whether or not you are maybe suffering from a particular type of infection. We can use bone marrow transplants to treat anemia, leukemia, and blood disorders, etc. However, this can cause rejection issues. So a good way around that would be to use cord blood transplant, so coming from the actual host, so we don't have any immunorejection problems. Alright, so this is talking about the vascular response in response to bleeding. It's called hemostasis. Basically what happens is we have damage to a blood vessel, and when damage to a blood vessel occurs, the area has to be contained and carefully controlled. So the first step of this is going to be called a vascular spasm, which is when the smooth muscle of a blood wall is going to contract to help stop or stave off the bleeding. The next thing that happens is platelet plug formation. Platelets are going to clump to this area to help stop the bleeding and turn into a clot. At this point, the clot is going to be kind of a gel-like, fiber-like, insoluble fiber mesh where the formed elements of blood are going to be trapped, and then it's going to tighten down in a process called coagulation or clotting. We have specialty clotting factors that are found in your blood plasma, but also released by platelets that might be caught in this plug, and also from the damaged tissue cells. So the combination of all of these together causes the clotting or coagulation response, which is a long cascade of reactions that's divided into separate stages. First, the formation of prothrombase, which is the activator, so prothrombin activator. So prothrombinase is going to convert prothrombin into thrombin, and that's going to lead to the conversion of soluble fibrinogen into insoluble fibrin, and that is going to be initiated by two different pathways, which can then come into a common pathway. So it's either intrinsic or extrinsic. So either we have damage from the outside or damage from the inside. Either way, they're going to end up reaching that common pathway, which is going to cause blood clotting. Now, one of the major factors for clotting or coagulation is vitamin K. And so we have to make sure that we have regular levels of vitamin K. So if you have issues with blood bleeding, like insufficient clotting, it might not necessarily be hemophilia. It might be low levels of vitamin K. And it's also going to be involved in fibrinolysis, which is taking that clot and dissolving it away. So the fibrinolytic system is the system by which small clots are removed, particularly clots that are inappropriate or are no longer needed once the damage is repaired. And we have something called plasmin or fibrinolysin that helps break down that clot by digesting those fibrin threads and inactivating several substances that you may have seen in those extrinsic, intrinsic, and common pathways, such as fibrinogen, prothrombin, and these blood clotting factors like 5, 8, and 12. Okay, so clotting in an unbroken blood vessel is called thrombosis, and deep vein thrombosis is something that's a very serious threat. This is why they tell you to walk around on an airplane, etc. Because if you sit for too long and then you end up with that deep vein thrombosis, kind of just getting to the point where it's maybe not quite as huge as it has been, and you stand up and all of a sudden the blood pressure rushes through those veins again, that can cause that clot to get knocked loose, and depending on where it lands, it can cause some serious problems in the rest of your body. They tell you to take low doses of aspirin to help with vasodilation, right? So help inhibit vasoconstriction and also help inhibit the chance of thrombus formation. And some people who already have clots can be injected with thrombolytic agents. This is going to be something where you're going to be under close watch of your doctor because, again, once those clots are dislodged, where they go can cause serious problems. So you want to make sure that you dissolve them entirely before they dislodge. So that's something that will be under the direct supervision of a physician. All right, so blood types and blood groups. We have major blood groups, and that's going to be A, B, and O. Remember, A and B are codominant, and they are both dominant over O. So if you had B and O together, you would appear to be B. If you had A and O together, you would appear to be A. However, if you have A and B together, you get both phenotypes, so you're AB. That means that someone with an A blood type is kind of up in the air in terms of their genetics because they can be either AA or they can be AO. All right, so in the AB system, we have these antigens A and B, that help determine our blood types, and our plasma is going to contain antibodies that are designated A and B, and they're going to react with them. So if you have a particular antigen, then you want to make sure you don't have the antibody against that antigen in your plasma. We also talked about the RH group. The RH group is going to be either positive or negative, so if you don't have the antigen, you're negative. If you do have it, you're positive. And we also talked about how we can have an issue with the compatibility between a mother who is RH negative but has carried an RH positive fetus already for her second child who is RH positive. We can have issues. It's called hemolytic disease of the newborn. It's something that's treatable, but we also are able to prevent it now, so it's something that she would take medicine for in advance. This blood type thing is very, very important for transfusions to make sure that you have a direct match. And it's also been very useful in proving paternity, or we can also use it for suspects being linked to crimes, etc. And again, we do this by blood typing, and if you guys were able to make it to lab, you know how to do blood typing. Hopefully you've at least watched the videos on how to do blood typing, because that's going to be something that I can ask extensive questions on if I choose. All right. So let's move on to the heart, cardiovascular system. So the heart is going to consist of, the Cardiovascular system is going to consist of the heart, the blood, and the blood vessels as well. The heart's that major pump that circulates the blood through all of the blood vessels. It's estimated we have 75,000 miles of blood vessels inside our human body, which is quite a lot. Cardiology is the practice of studying the heart. Heart's found right in the middle of the body between the lungs, and 2/3 of it is left of the midline. So when you put your hand over your heart, it's actually right on the middle, not to the left like they say when you do the Pledge of Allegiance, although it is a little bit to the left, but not far enough to the left to be your entire hand over. And it's held in place by something called the pericardium, which has an inner and an outer layer. So it has an outer fibrous pericardium and an inner layer that's a serous pericardium. And the serous pericardium also has 2 layers, parietal and visceral, which really just depends on which layer it's lining. Is it lining the heart or is it lining more towards the lungs? And in between there, we have the serous pericardium. Between the parietal and the visceral layers of the serous pericardium, I apologize, we have the pericardial cavity, which is going to be a region that's filled with the pericardial fluid that helps reduce friction between those 2 membranes. And if we end up with an infection or an inflammation here, that's called pericarditis. It can be very dangerous because, as you can imagine, it can cause pressure and weakening on the heart. If we're doing a dissection of the heart itself, we have 3 layers of the heart wall: the epicardium, the myocardium, and the endocardium. The epi is going to have the mesothelium and connective tissue. The myocardium has cardiac muscles. And the endocardium has endothelium and connective tissues as well. And if we get an infection here, that's called myocarditis and endocarditis. So a more specialty description of where the infection is located. Heart split into 4 chambers: 2 atria, 2 ventricles. That's the left and the right. Let's see, we also have these regions on the outside called auricles and sulci. So pouches are auricles and sulci are grooves. The right atrium is where blood's going to be coming in from the vena cava. We have 2 regions of the vena cava, superior and inferior vena cava. They both feed in, as well as from the coronary sinus, which is going to come from coronary circulation, basically blood that has kept the heart tissue alive. And that's going to be a really short circulatory route. It's going to do coronary circulation and dump right back into the right atria to be reoxygenated, because the muscles of the heart are going to be using up so much oxygen that just that short little trip through, it's going to be almost entirely deoxygenated when it comes back. All right, so we have an area between the left and right atria that's called the Fossa of Allis. And if we were to test you on, which we aren't, if we were to test you on development, you would know there's a region called the foramen ovale, whereby the left and the right atria actually shared a volume of fluid back and forth, such that if the left ventricle contracted with such force that it might rupture, instead of rupturing, it would just send the fluid back into the right atria to start the circulatory process again. And some individuals could still have a small hole in their heart, which would cause an immediate cause for surgery, possible a couple of surgeries, so that we can close that off so that we don't have leakiness back in the heart chamber. All right, in general, blood comes into the right atria and then passes to the right ventricle through the tricuspid. From there, it's going to leave through the pulmonary trunk to through the pulmonary semilunar valve out into the lungs. After pulmonary circulation, it returns back into the left atrium through the pulmonary veins. The only time we're going to see oxygenated blood in the veins, as opposed to normal, we're going to see oxygenated blood in the arteries. Then blood coming into the left atrium is going to pass into the left ventricle through the bicuspid or the mitral valve, and then that left ventricle is going to pump and force the blood out through the aortic semilunar valve into the aorta. Additionally, the one more difference between the fetus and the adult is that we have a ductus arteriosus in the fetus, which becomes the ligamentum arteriosum. So we actually have a 4th shunt that comes off of the pulmonary trunk in the aorta of the fetus that is not found in the adult. It's just going to close off into a ligament called the ligamentum arteriosum. All right, as we know, the left chambers are going to be thicker, namely the left ventricle is going to be the thickest. And the thickness of the myocardium is going to vary according to how the chamber functions. Atria is going to be thinner because they don't need to have much strength to deliver the blood into the ventricles, but the ventricles are thicker because they pump blood greater distances. And in general, the right ventricle is thinner than the left ventricle because the left ventricle walls need to be able to be really strong to pump blood through the body, because we have more resistance when we're pumping blood through the aorta than when we are pumping blood into pulmonary circulation, which is what happens with the right ventricle. We also have a region of the heart that's the fibrous skeleton, where we have the valves attached, where cardiac muscle bundles are going to insert. And these are going to help keep the valves in the correct position so they don't get overstretched when blood passes through them. And additionally, they act as an insulator of the electricity so that we don't have action potential spreading willy-nilly and are actually carried in a direct pathway. So we don't have any spread of action potential from atria to ventricles except for the ones that we would like to have. Let's see. So the atrioventricular valves and the semilunar valves are going to work equal and opposite to one another. So when one set is open, the other set is closed. Also, for just a small fraction of a moment, all 4 of them are closed in between. So we have 2 open, all 4 closed for a moment, the other 2 open. All 4 closed, the other 2 open, right? Just for a second. So atrioventricular valves are going to be between the atria and the ventricles. They are going to prevent backflow of blood into the atria. And that's assisted by the contraction of papillary muscles that pull those chordae tendente down so that the valve cusps stay closed and don't evert all the way like an upside-down umbrella. The semilunar valves are going to be where the valves are, where the blood is going to leave the heart and go into arteries. They're either going to go out into the pulmonary circulation or out into the aorta for general systemic circulation. And these semilunar valves open when pressure in the ventricles exceeds the pressure in the arteries. Okay, so the right side is going to pump out for the pulmonary circulation, but the left side is going to be the pump for systemic circulation. So basically it's going to be sending oxygenated blood out from the lungs into the vessels of the body. And the right side of the heart is going to be a pump for pulmonary circulation. So again, that's going to be where we are receiving deoxygenated blood from the body and sending it out to the lungs for oxygenation. Okay, again, so coronary circulation is going to be when we have the blood that's coming directly out of the heart. There's a little teeny tiny trickle right off at the beginning of the aorta that's going to send blood into the coronary arteries, which is going to actually feed the myocardium, and it's going to carry oxygenated blood. And then the coronary veins are going to carry deoxygenated blood, and that's going to dump directly back into the right atrium, into the coronary sinus. If we end up with tissue damage to a coronary artery, or we end up with blockage to the coronary artery resulting in tissue damage to the heart muscle, then we can end up with issues and might need a bypass. Sometimes this can cause problems because we can reperfuse that tissue and cause further damage because we have free radicals that have built up during that what was called a heart attack. And so we want to make sure that we can get oxygenation back to those tissues, but also use drugs that can help lessen the damage during that reperfusion event. All right. So cardiac muscle fibers are going to be similar to, but a little bit different physiologically to skeletal muscle fibers. They're shorter in length, they're larger in diameter, and they're square, as opposed to being circular if you do a transverse section. Additionally, they're odd in that they exhibit branching. That means that they're going to kind of fork off and make Ys and odd shapes, which allow them to attach to more than one other cell at a time. But it's going to be everything that we saw before. We talked about skeletal muscle in terms of bands, zone, Z-discs, etc. They're also going to require a lot of calcium that's going to come from extracellular fluid in order to have a continuous contraction. And there's 2 major networks of the heart, the atrial network and the ventricular network, which, as you might imagine, are going to work in terms of making the atria contract versus the ventricles contract. We have a conduction system whereby we have, again, these cardiac cells are autorhythmic. That means they're self-excitable. They're going to create action potentials to trigger heart contractions. And that's going to start from the sinoatrial node, which is known as the pacemaker, pop over to the atrioventricular node, follow down the atrioventricular bundle, which is also known as the bundle of His, into the right and left bundle branches so that we can conduct our myofibers. Epinephrine can modify the heartbeat. That means that it can make it stronger or make it faster, but it's not going to be responsible for establishing the fundamental rhythm. That's going to be, a fundamental rhythm is going to be established by the heart itself. If we look at the action potential during contraction, first we end up with a rapid depolarization, so it would look like this, then a plateau, then a repolarization event. And the refractory period is going to be a time frame where we can't have a second contraction triggered while the first one is working itself out. Typically, the refractory period is actually longer than the contractile period itself. Cardiac muscle need a lot of ATP, so they rely on aerobic cellular respiration to create ATP. That means that we have a ton of mitochondria in these cells. It also produces some ATP from creatine phosphate, which is going to be a short-term burst of energy, but it's not going to be sustainable. It's only going to work for the first, 30 seconds or so. And individuals that have CK or creatine kinase in the blood typically have had a myocardial infarction recently, so that indicates that the cardiac muscle has actually been injured. We can use an EKG to look at someone's cardiac cycle or heartbeat, and we talked about all of the different steps of the EKG, which include the P wave, which is when we're seeing the depolarization of the atria, and the sinoatrial node is going to spread information out along the atria. And then we have the QRS complex, which is when we have the ventricular depolarization occurring, so that it's when the ventricles are going to be contracting and getting their impulses. And we also have a T wave, which is the repolarization of our ventricles. Yeah, so this is basically telling you all of that. During this cardiac cycle, we have atria relaxing and ventricles relaxing alternately. So we have basically atria contracting, then the ventricles contract, then the atria contract. Remember, there's a moment in between where we don't have any contraction at all. So systole is the contractile event. Diastole is the relaxation event. And during atrial systole, we're going to have contraction again of the atria. And then during ventricular systole, we're going to have contraction of the ventricles. Then we have a relaxation period where both atria and the ventricles are relaxed. We talked about how heart sounds. So we have the lub-dub, lub-dub, and if we had an abnormal heart sound, we might have something like a heart murmur, so that we have a weird flow noise that might happen before or after that lub-dub sound. All right, cardiac output is going to be defined as the volume of blood ejected that's going to come out of each ventricle, but really from the left ventricle, into the aorta each minute, because we're going to have the same amount of blood going out of the left ventricle as out of the right ventricle. So we have the same amount of blood is going into pulmonary circulation as is going into systemic circulation at any given moment. Now, cardiac output is going to be equivalent to stroke volume, which is the amount of blood that's ejected with each contraction times the heart rate, which is the number of beats per minute. So how much blood is going per beat and how many beats do you have per minute? Going to give you a total amount of blood flowing out per minute. For stroke volume, we have three major factors. That's going to include preload, degree of stretch, and contractility. Also the forcefulness of the contraction, and then it's also going to include the afterload, which is basically how much pressure has to be exceeded in order for blood to actually eject from the ventricles. So how much pressure is already in the blood supply that it's going to be ejecting into. And the Frank-Starling law, again, is what's going to help equalize the output from the right and the left ventricles to systemic and pulmonary circulation. Okay, so the heart rate is under autonomic regulation and chemical regulation. And then other things that factor into your heart rate include your age, your physical fitness, and your gender. We talked about exercise being really important for the heart, and that it's going to help increase oxygen demand in the muscles, which is going to increase the pressure on the heart, because the heart's going to then have to circulate with the blood a little bit faster. So to get a better increased cardiac output, you want to engage in aerobic activity at least 3 times a week for about 20 minutes to help improve your lung function, decrease your blood pressure, and help keep your weight under control. Now, we talked about different types of help for failing hearts. We're not going to focus extensively on that, I don't believe, for this lecture or for the lab exam. But basically what happens with the different versions of help for failing hearts is we can replace the entire heart, or we can replace portions of it, or we can reroute our own muscles around the heart and then induce those muscles to contract. So we're pushing the heart in what is now a beat controlled by a pacemaker that's installed in our chest muscles. And again, I'm not going to talk about development or very many disorders. Okay, so now we're getting to the good stuff. These are the images that you are going to start seeing when you are, or these are everything that is in these series of slides is eligible for you to be able to see as a D-labeled ABCD style images. So for this one, you need to know the difference between the heart and the systemic circulation versus the pulmonary circulation, a pretty easy one. This shows you the external anatomy of the heart. Right atria, right ventricle, left atria, left ventricle. If you were in lab with me, then you talked about the path the blood flows into the heart, right? Namely through the superior and inferior vena cava and coronary sinus into the right atrium, from the right atrium into the right ventricle, from the right ventricle out into pulmonary circulation, through the pulmonary trunk into the left and right pulmonary arteries, then back in through the pulmonary veins, into the left atria, then into the left ventricle, then out of the left ventricle, out through the aorta, 3 major branches of the aorta, etc. So all of that is totally fair game. So this is going to show you the same thing, but from behind. This is the posterior surface. Other thing that was missing previously was coronary circulation. We didn't really, I mean, I guess we kind of saw it, but I wasn't talking about it. But these are the coronary circulation. So that's going to be circulation to get oxygen directly to the heart muscle itself. Okay, again, all of those images, totally fair game. Which valve is which? Where do we go from what ventricle? Which one's going into pulmonary circulation versus systemic circulation? Which ones are the semilunar valves? Which ones are the atrioventricular valves? All of that, totally fair game. All right, so basically blood is coming in, again, from the superior and inferior vena cava as well as through the opening of the coronary sinus directly into this right atrium. From the right atrium, it passes through the AV, or the tricuspid valve, into the right ventricle. From the right ventricle, it's going to pass out here through our pulmonary valve to go out into the left and the right lungs. Then we're going to have the return in through the pulmonary veins into that left atria, right here for the left pulmonary veins, sorry, into the left atria. From the atria, we're going to go through the mitral valve, and then the left ventricle is what's going to contract with a much stronger force. You can see the difference in the muscle already, right? Here's the right, here's the left. Look how much thicker. And that's because this force is going to have to contend with the back pressure from the aorta, whereas this one is just going to be pushing it out into the lungs, which have already cleared their blood because that blood's coming back in through these pulmonary veins. So again, anything on here is going to be totally fair game. This here is the fourth of the ducts, if you will. They come off of the aortic arch. It's not now present because this is an adult heart, but in a baby heart or in an infant heart, you would see this ligamentum arteriosum would actually be a connective tissue, or would have the blood supply connected from the aorta into the pulmonary trunk. You would also see that we have this Fossa of Allis is going to be like kind of a precursor, predator. We would see that we would also have a hole that would open between the left and the right atrium. All right, this one's talking about coronary circulation. So basically, you need to know which ones go the coronary arteries and the cardiac veins, how they supply and drain the myocardium of blood. So here's our right coronary artery. Here's our left coronary artery. Left is going to split in two. Here's the pulmonary trunk and the circumflex artery. Sorry, here's the pulmonary trunk. Sorry. Pulmonary trunk is for leaving or ejecting out of the heart. I apologize. It has nothing to do with coronary circulation. So here's our left coronary artery. Here's our circumflex artery. And then here's our anterior interventricular artery. For return from this area, we'll be coming up through the great cardiac vein. On this side here, we have our right coronary artery. And then here we have the marginal artery, which is going to branch off of that. And then coming together, we're going to have, here's our veins, the small cardiac vein, the anterior cardiac vein, etc. All of which are going to feed back into the right atria of the heart through that little drainage for the coronary sinus. So here's the coronary vessels on the posterior surface. Here's our posterior interventricular artery shown in red, and our middle cardiac vein shown in blue. The marginal artery on this side, which you're actually able to see from here. Hey, buddy, we're talking about the heart. And then here's our small cardiac vein in the back. We also have the circumflex artery and the great cardiac vein that are going to be found on the posterior surface too. All right, so that's going to sum up the heart. Now we're going to talk about circulation. So circulation is going to talk about all sorts of stuff, including hemodynamics, which is basically how we change blood flow and how we distribute blood flow and how we can regulate blood pressure. Okay, buddy. And also, we have different histology, so we're going to need to know the anatomy of and the primary routes of both the arteries and the veins. Okay, so the basic structures of the vessels include the interna, the tunica media, and the tunica externa, which is going to be the three major layers of a blood vessel. The interna is going to be the one closest to the lumen that's in contact with the blood. And the media is going to have smooth muscle and elastic fibers. And the tunica externa is going to have elastic and collagen fibers and perform the most protective layer of all. The creation of new blood vessels, that's called angiogenesis. Cancers are able to do this. And so sometimes we will treat people who have cancer with drugs that inhibit angiogenesis or angiogenic inhibitors. All right, so arteries are going to carry blood away from the heart to the tissues. And again, it's going to have three major regions, including a tunica interna, a tunica media, and a tunica externa. And the major properties of arteries are going to include elasticity and contractility. So elasticity is important because it's going to allow the arteries to accept blood under pressure. This isn't going to be as big of a deal for venous return because it's not going to be under great pressure. Okay, bud, take them off. And contractility is important because we have to be able to increase or decrease the size in order to stave off bleeding or to put blood towards areas that need it the most. Right? Over to your foot first. All right, so arteries are going to, the larger arteries are going to have more elastic fibers. Those are mainly going to be the elastic arteries. And that's because they're going to be getting blood that's under direct pressure, still receiving part of that lub-dub, right, directly from the heart, and help propel it onwards. Let's see. These can also be called conducting arteries because they're going to help conduct the heart, blood from the heart into muscular arteries. Here you go, step into it. And they're going to help serve as a pressure reservoir as well. Now, we have a lot of areas where we have arteries that are going to branch to each other, into and back and forth from each other, like a neighborhood routes, so that we can supply blood to the same region. These are going to offer alternate routes for blood to be able to get to a particular tissue or organ. All right. If they don't anastomose, they're called end arteries, and these are going to be a little bit trickier. So if we have occlusion or a blockage in an end artery, that's going to interrupt blood supply to the entire region of the organ, which can cause necrosis or death. So this is why anastomosis are very important, because it's going to allow a secondary route for blood to get supplied to a particular tissue. All right, so we talked about arteries going into arterioles. So arterioles are smaller arteries that regulate blood flow into a capillary. Perfect. And capillaries are found everywhere in the body. They're going to help deliver things to the inner organs. So it's going to help deliver everything that's coming out of the blood, as well as pick anything that needs to come back out of the tissues, which is going to come from the tissues into the interstitial fluid, etc. Now, capillaries have multiple different types, including sinusoid capillaries, etc. But basically, they're going to serve as a connective tissue between the veins and the arteries. Again, three major types of capillaries are going to include continuous, fenestrated, and sinusoid capillaries. From capillaries, we're going to end up with the blood returning through veins, entering first into venules and then into veins, which is going to be a drainage system. So now we have lost most of the pressure that's going to be working at this point. And we're going to be working mainly on suction, if any pressure at all, and also skeletal muscle is going to serve to help push the blood through these one-way valves. So we have the same three tunics as arteries, but we have a thinner tunica interna and a thicker tunica externa. And so they're going to be thinner walled than arteries. Can you be quiet, please? So capillaries are going to allow substances to leave by diffusion and bulk flow. You need to stop. All right. So again, we can get out of the capillaries by multiple ways. One by diffusion, that says diffusion for some reason, which is going to be the basic method of capillary exchange, whereas substances like oxygen, etc., are going to come out through here. And that's all going to happen down a concentration gradient. Again, from high concentration to low concentration. This should be transcytosis. Goodness gracious. Who edited this document? Me, obviously. Some things are going to enter across the capillary membrane by what's called transcytosis, which is, again, going to be by vesicular exchange. And then things are going to come back in through bulk flow, basically through resorption and filtration, which is how pretty much everything except proteins is going to be coming along through hydrostatic and osmotic pressures. All right, so we talked about hemodynamics in terms of blood pressure, cardiac output, and total resistance, and mean blood pressure. So cardiac output we talked about previously being the equivalent of stroke volume times the amount of beats per minute, but it's also going to be equal to the aortic blood pressure divided by the total resistance, which is what the blood is going to be facing when it's coming out of the aorta. And some of these factors are going to include things like cardiac output, factors that affect blood pressure, are going to include things like cardiac output, total blood volume, blood viscosity, so how thick, meaning like how much water is in there relative to salts and other items, which is going to affect things like resistance, as well as the elasticity of those arteries. So as blood leaves the aorta and enters into systemic circulation, the pressure is going to fall. So it starts off really high as it's heading out of the aorta in that lub-dub, and eventually it's going to progressively fall down to about 0 by the time it reaches into the right atrium, which is when it's going to be headed back into, circulation again. So again, venous return happens because we have a pressure gradient between the venules and the right atrium, so we have suction that's occurring, and we also have muscular contractions that are happening, and valves in the veins that are going to be those one-way valves that are going to be pushing things forward but not allowing them to come back. And then breathing is also going to create pressure changes as well. Okay. In the brain, we have a region called the cardiovascular center, which is a group of neurons that regulate heart rate, contractility, and blood vessel diameter. And this all happens via sympathetic and parasympathetic fibers. And sympathetic fibers are going to go along what's called cardio-accelerator nerves, and parasympathetic impulses along the vagus nerve. They're going to do equal and opposite. So basically, sympathetic is going to increase heart rate and contractility. Parasympathetic decreases heart rate. Let's see. We also have baroreceptors that are found in specialty regions such as the cardiac sinus and the aortic arch. And these are going to be regions that are going to detect the stretch of the blood vessels of the atria, etc., and that's going to allow us to detect blood pressure based on how much stretching is occurring. And if the pressure falls too far down, then the baroreceptors are going to start accelerating our heart rate, increasing heart contractile forces, and vasoconstricting, basically trying to maintain blood supply to the areas that need it the most. We also have specialty receptors that are chemical receptors called chemoreceptors, as well as baroreceptors that it will measure things like pressure. We have specialty receptors that monitor oxygen, carbon dioxide, and hydrogen ion concentration as well. So blood pressure is under hormonal regulation, namely angiotensin II, epinephrine, norepinephrine, and ADH, as well as ANP, are going to affect both blood pressure and blood flow. And they can do this a couple of ways. They can alter the cardiac output or change resistance or adjust the total blood volume in general. And if you need more information about that, you can see table 21-2. We know how to check a pulse. Measurement of blood flow, we did this when we did this in lab, so you'll be taking the blood cuff, and if you haven't done it in lab because you weren't present, then you hopefully at least watch the video, and we'll be doing it in your nursing classes. But what happens is you're measuring the difference between systolic and diastolic blood pressure, and you're able to actually hear noises that are called Korotokov sounds, so that you can actually tell the different stages of the compressions of the heart. And then these are your normal pressures, should be about 120/80. And you're looking at, again, systolic over diastolic. And the difference is going to be called pulse pressure. So if you're going to subtract the two, that's about pulse pressure. It should be approximately 40 milligrams of mercury. All right, so we talked about shock. Shock is defined as the inadequate perfusion to meet the body's needs, which causes disruption in cellular metabolism and cellular death. Different types of shocks include hypovolemic shock, cardiac shock, vascular shock, and obstructive shock. All right, so the different types of shock are basically going to be defined as how the shock occurs. So hypovolemic shock occurs when we have low blood volume, so hypovolemic. We also have shock that can happen when the heart is not functioning properly, called cardiogenic shock, as well as shock because of inappropriate vasodilation, which would be vascular shock, or if we've obstructed blood flow from one region to another, that would be called obstructive shock. And some of our responses to shock can include that renin-angiotensin-aldosterone system, or secretion of antidiuretic hormone, or activation of the sympathetic division of the autonomic nervous system, or we can also release local vasodilators to help try to get more blood circulating. Classic symptoms of shock include clammy skin. Basically, they are trying really hard to pump blood, but they're failing extensively. So they're going to have a weak pulse that's very rapid, so it's not able to perfuse the tissue. Sometimes they can be sweating, but that is the beginning stages. Also, we can have obviously really low blood pressure. Blood pressure lower than 90 is considered really low. This results in altered mental status, right? The brain's also not getting what it needs. And decreased urinary output. There's no water to go through the urinary tract, which results in thirst and also blood acidity. All right, so circulatory routes you are going to need to know. We have really nice images of those. I think I'm going to just get forward to those images here. All right, so this is going to show you the arteries. Again, coming out of the heart, we're going to enter into the aortic arch. From there, we are going to split off. We have three major branches. It's going to include the subclavian and the brachiocephalic and the common carotid, right? Off of there, we're going to have the same on the left and the right arm, so I'm just going to do the one arm, but we're going to do the axillary, and then that's going to branch into the brachial, into the radial, the ulnar, and if we head down to the hands, we get the palmar arches. If we're coming down the back of the heart, that's the back of the aortic arch, we're going to go down to the abdominal aorta, which is then going to feed all the inner organs, and we'll talk about that in its own separate image. And then we also have that splitting into the iliacs. So we have the left and the right iliacs, which then are going to split into the femoral. We have the deep femoral, which services the thigh, and the femoral, which is going to feed down through the popliteal, which is the knee, and then head into the foot. In the lower limb, we have popliteal feeding into the tibial, and so we have posterior and anterior tibial, as well as the fibular, and in the foot, dorsal peds, and the plantar arch. So you are responsible for knowing the circulatory routes. Anything that's depicted here is fair game. All right, this is going to tell you how we are going to be, how the blood is going to exit out of the heart, and where it's going to go next. So exiting out of the heart, we're going to go out through the ascending aorta into the aortic arch. The aortic arch, as I mentioned, splits three different times: brachiocephalic, common carotid, and subclavian. Then the aortic arch then continues down into the thoracic aorta, which is going to serve the abdominal aorta, but that's not what's depicted here, so that's going to be kind of the end of that side. On the other side, we're going to head up into the right common carotid and the left common carotid, so that's going to service the head and neck. Brachiocephalic is going to go out here into the right subclavian, which then feeds into the right axillary, brachial, radial ulnar, and then the palmar. So we have the deep palmar arch, superficial palmar arch, and the digital arterioles. And that's going to be the same on the left side as well, so it's only depicted once. So you are going to need to know the path of blood flow exiting the heart through systemic circulation, yes. This shows the lower limbs. So we're heading down. We've split through the iliacs. Now we've gotten to the common iliac, which is going to split into the internal and the external iliacs. From there, we're going to head into the femorals. The femoral has an internal, a deep femoral, and an external, just the regular femoral. The deep femoral services the thigh and actually splits even further into the lateral femoral circumflex and the medial femoral circumflex. And then the femoral itself runs down. It's going to meet up with the popliteal. Again, we have the anterior tibial, posterior tibial, fibular, dorsal peds, and the plantar. We have the lateral medial arches and the lateral medial plantars and the dorsal and plantar arches. So again, this is going to show you the route of arterial supply to the lower limb. Right external iliacs into the femoral of the thigh. The femoral splits into the deep femoral, which splits further into the middle and the lateral femoral circumflex. The femoral itself is going to run into the popliteal, which splits. We also have a descending genicular, which is right on the skin of the thigh, the leg joint, right over here. The popliteal then splits in the posterior and anterior tibial and the fibular. Here, to my hair. And the fibular, which then is going to feed down into the lower parts of the foot. All right, so if we're looking at the abdomen, as we head downward, one of the first things we're going to encounter on our way down is the celiac trunk, which then splits into common hepatic, left gastric, and splenic. Right? Next one we're going to hit is going to be the hepatic artery.
I don't like this one.
The hepatic artery is going to have the hepatic proper, gastroduodenal, which is going to split into the stomach and the duodenum. We also have the cystic, which is going to do the gallbladder. The right gastroepicolic. You can take that outside then, please. And then we have the superior pancreatic duodenal, which is going to service the duodenum. And next one we're going to hit is going to be the superior mesenteric artery. The superior mesenteric artery is going to split as well, servicing the inferior pancreatic duodenum, which is going to service the pancreas and the duodenum. We also have the middle colic, right colic, and ileocolic of the large intestines, as well as the intestinal arteries of the small intestines. Let's see. Next, following down, we have the branches off the splenic artery. That's this guy here. And then we have the inferior mesenteric artery. Oh, the splenic is going to feed the pancreas and a little bit of the stomach. So left gastroepiploic. Again, continuing down, inferior mesenteric artery. That splits into the left colic, sigmoid, and the rectal. All right, so that is all arterial supply. So next we're going to talk about venous return. Venous return is going to be, remember, it's a series of drainage, but it is going to overlap a lot with the arterial supply. So we're going to start with our hands. We have the digital veins, palmar venous arches. We have a lot of anastomoses here, but we're going to have the ulnar and the radial return, as well as this region here called the median antebrachial. We have the median cuboidal, the basilic, which feeds up into the brachial. That eventually is going to feed into the axillary, all right? All of that is eventually going to feed into the subclavian, down into the superior vena cava, and eventually into the heart. All right, as we come down through the head, and we get down to the external and internal jugular, as well as the vertebral. And then that's all, of course, going to feed into the superior vena cava. Coming up from the abdomen, we'll do in a different lecture, a different image, but that's going to do the same thing, drain upward into the inferior vena cava. But if we look at our feet, we're going to start with the plantar venous arch, the dorsal venous arch. These are going to feed up into the fibular. We also have the small and the great saphenous. The great saphenous is going to run the full length of the leg. The small saphenous is going to meet at the popliteal. Additionally, we have the femoral and the deep femoral, just like we saw before. Those come up into the iliacs, the external and internal iliacs, which meet at the common iliac, and then are going to feed up into all of the different branches of the abdomen, and we'll talk about those branches of the abdomen right here. All right, so again, this says the same thing. It's going to talk about where we are having drainage routes from the abdominal organs back into the trunk here, which feeds up into the inferior vena cava. All right, so in order to get back to the heart, we have to get back to the superior vena cava or the coronary sinus or the inferior vena cava. So again, we're going to do that. Here's our external iliac and our internal iliac coming up. We're going to get the lumbar veins coming in, the gonadal veins, the renal veins, the adrenal veins, the phrenic veins, which are going to going to be part of the diaphragm. So get stuff out of the diaphragm. Then we have coming up against the inferior vena cava. Then we have the intercostal veins. These are all going to drain as well. Esophageal veins. That's all going to come. We have the azygos and the hemizygos. All of this is going to be draining into the inferior and superior vena cava. If we look at the arm, again, we have the digital veins, palmar venous arches, feeding up through the ulnar and the basilic. We also have the median antebrachial, the radial. There's a lot of anastomoses in here. Again, those are going to come up and meet here. We have the median cuboidal, which is going to run up into the basilic and eventually become the axillary. On this side, we have the cephalic at the top, and it's going to run into the median cuboidal down there. All right, so the veins of the lower limbs, Starting at the foot, we have the plantar venous arch and the digital, a dorsal venous arch feeding up into the anterior tibular and the fibular, which both feed into the posterior tibial and into the popliteal. From the popliteal, that's the knee one, we're going to feed up into the deep femoral. I also have missed here the small saphenous, which is going to be on the outside, and the great saphenous, which is going to be on the inside, running alongside the femoral, basically the full length of the limb. And the femoral circumflex branch is going to feed into the femoral from the deep femoral, which is on the outside here. Looking at the back, it might be a little bit easier to see because the deep femoral services the inside of the thigh. All those are then going to feed up into the iliacs. Looking at the back, we've missed, so you have the anterior tibial, posterior tibial, we've already seen, feeding up to the popliteal. Here's, again, the saphenous. Here's a small saphenous and the great saphenous. We have the deep femoral and the femoral. All of those are going to converge. Femoral circumflex is going to feed in as well. All those are going to converge with the glutes as well into the iliacs. All right, so here's our abdominal setup, but we're now looking at the hepatic portal system. Basically, anything that gets into the hepatic portal vein is going to be coming from multiple sections, from the superior and inferior mesenteric veins. And that's going to then have, remember, these veins that are coming out of this area are going to have a lot of nutrients that are coming in. So we're going to have deoxygenated but highly nutrified blood flowing into the liver, as well as feeding the liver highly oxygenated blood as well, straight off of from like the mesentery, from straight off of the aorta as well. So the hepatic portal vein is going to get blood from the superior and inferior mesenteric veins, and also is going to take the nutrient-rich blood into the liver so it can help break down any toxins or microbes that are found there and help regulate the blood sugar. All right, so coming upward, we have the inferior mesenteric vein and its tributaries. That's here. That's going to feed into the left colic, sigmoid, or be fed by the left colic, the sigmoid, and the superior rectum. Okay, we also have the splenic vein and its tributaries. That's here, which is then going to meet up right above the pancreas with the superior mesenteric vein and its tributaries. So the splenic vein is going to feed the left part of the stomach, and also the right part of the stomach here, and the pancreas. And the superior mesenteric vein and its tributaries is going to be fed by the intestines, namely the small intestines. And the ileocecal, so from the ileum and the ascending colon, and the right colic as well. And the pancreoduodenal, that's going to be the superior mesenteric. So those are going to be the major sets of venous return that you're going to need to know here from the abdomen. All right, so that's going to finish us off here for circulation. So now we're going to move on to respiration. And respiration serves to help supply oxygen and eliminate carbon dioxide in the system. So again, we're going to have the cardiovascular system and the respiratory system working hand in hand. So the respiratory system is going to be the site of gas exchange, and the cardiovascular system is going to take those gases and transport them throughout the body. So if we have failure of one, it's the same as the failure of the other in terms of the effect on the body, mainly rapid death of cells from oxygen starvation and death and buildup of toxins in the body. So respiration has three major processes. The first is ventilation, which is the physical act of breathing. Then we have internal or pulmonary respiration, which is when we have gas exchange across the membrane of the lungs. And internal respiration, which is when we have gases that are delivered directly to the tissues themselves. Respiratory anatomy is going to consist of the nose, pharynx, larynx, trachea, bronchi, and lungs. And we split it up in two different ways. We can split it up into upper and lower respiratory system. So the lower respiratory system is going to start at the larynx and trachea, and the upper respiratory system is everything above that. And then we can also split it up into the conducting and the respiratory zones. Right? So the conducting zone is just going to be where we are channeling the air, and the respiratory zone is going to be the site of gas exchange. So the channels of air is going to include the pharynx, larynx, trachea, etc., down into the terminal bronchioles, anything that gets air into the lungs, until we hit the respiratory portion, which is where gas exchange actually occurs, including respiratory bronchioles, alveolar ducts, alveolar sacs, and alveoli. So I've talked about all the different types of parts of the nose previously. We should know this by now. In the larynx, we have some interesting things. So we have vocal folds that are true vocal cords as well as false vocal cords. The true vocal cords are going to produce sound, and they do that by way of these specialty muscles are going to get tighter or more lax to produce higher or lower pitches. And if we end up with laryngitis, that's basically going to be an infection or an inflammation of the larynx caused by respiratory infection. All right, so in the trachea, we're going to split into the left and right pulmonary bronchi. And then from there, we're going to split from the bronchi into the secondary bronchi, tertiary bronchi, bronchioles, and terminal bronchioles. Yes, when I'm done. And so if you look at the histology, we're going to see changes as we move down the bronchial tree, namely with the different layers. So if we have regions that are going to be that mucous membrane region at first, then it's going to turn, so first it starts off being ciliated and pseudostratified with many goblet cells, which are mucus secreting cells, and eventually becomes non-ciliated cuboidal epithelium in the smallest bronchioles. Additionally, in the trachea, we have C-rings of cartilage, which are going to be replaced by plates of cartilage on the bronchi, and eventually the cartilage disappears entirely in the bronchioles. So there's no cartilage at all in the bronchioles. And as we start decreasing the amount of cartilage, we're going to increase the amount of smooth muscle. As you may know, lungs are a paired organ that are going to have a pleural membrane that surrounds them. Same as what we see with the heart, we're going to have the visceral and the parietal membrane. That's going to be the parietal and visceral pleura. Parietal pleura being the outer layer, visceral being the inner layer. And inside we have a pleural cavity, which is a serous fluid layer that's going to have lubrication capability to help make it that when you're breathing, you are going to reduce your friction. And we can end up with air ended up in that pleural cavity called pneumothorax, which can cause serious problems because then you're not able to actually pull in air from your lungs because it all has to do with pressure. And if air in that region, inside the pleural cavity, then we're not going to be able to fully inhale the lungs. The right and the left lobes of the lungs are different in that the right lung has 3 lobes, and the left lung has 2 lobes with 1 fissure and 1 depression separating them, as well as a cardiac notch. As we follow down, we get to secondary bronchi. These guys are going to then branch into tertiary bronchi, which are going to then supply tissue called bronchopulmonary segments. Each of these has specialty lobes or lobules. Inside that, we're going to have lymphatic tissue, arterioles, venules, terminal bronchioles. We're going to be providing lymphatic tissue. We're going to be providing blood supply, and also these respiratory bronchioles and alveolar ducts and alveolar sacs, which are where the site of actual gas exchange occurs in the alveoli. Now, alveoli have 2 different types of cells, type 1 and type 2 cells. Alveolar cells are actually epithelial cells that are going to have the gas exchange occurring. Septal cells are going to secrete a mucus or alveolar fluid, which keeps it, so it has a surfactant on it, keeps the alveolar cells moist and lowers the tension, so we can help not only prevent collapse of the alveoli, but also allow for adequate gas exchange across the alveolar capillary membrane. Okay, so let's talk about the difference between pulmonary ventilation, which is when we're breathing inside. So that's going to be basically the very first step of everything is inhalation. After that, we have external respiration and internal respiration. So pulmonary ventilation is going to be the very first step where we start with inhalation. And this is going to just be the physical act of breathing, all of which depends on pressure changes from the inside and the outside. So basically when we contract down our diaphragm, that is going to make it such that our lungs expand so that the pressure inside our lungs gets lower. That means it's going to pull air in from the outside. And then when we push that air back out, that means that we're going to be putting our lung pressure pushing against our lungs, meaning that we're going to increase the pressure inside the lungs such that the air flows outward, even though the outside pressure is going to be staying constant. So the very first step is going to contract your diaphragm, which is your inspiratory muscle, which results in inhalation, which is when we have pressure inside the alveolar sacs falling below the atmospheric pressure so that air is going to come in. Right, so the lungs are going to expand, which decreases alveolar pressure, so the air moves along the pressure gradient into the lungs. Whereas during exhalation, we have the opposite happening, where we're going to have contraction and we're going to have pressure forcing the air outward. We have specialty muscles that are accessory muscles of inspiration during forced inhalation. So when you inhale as hard as you can, you start using other muscles that you don't use during regular breaths or regular inhalation. Again, expiration happens when the alveolar pressure is higher than atmospheric pressure, which happens because you're relaxing the diaphragm, and all the external internal costal muscles are going to relax as well, which is going to cause recoil in the chest and lungs, meaning that the pleural pressure, the intrapleural pressure, is going to increase as your lung volume decreases, meaning that air is going to leave your lungs and enter into the atmosphere. Okay, exhalation can be active or inactive. So again, we just talked about active inspiration. So forced or labored breathing can be when we are um, happen when air movement is impeded out of the lungs. And again, forced expiration is when we are forcing this to happen. So we're employing contraction of extra muscles that we don't normally employ, including the internal intercostals and abdominal muscles. Okay, specialty breathing patterns include eupnea when we have normal variations, that's normal breathing. Apnea is when we are holding your breath. You may have heard this in relative to like sleep apnea. Dyspnea is when we have difficult breathing or it hurts for the individual to breathe. Tachypnea involves very rapid breathing rate. It's normally combined with abnormal circulation. This is one of the first symptoms of shock as well. Specialty types of breathing include costal breathing, where we're using your your rib muscles to help expand your lungs, so your intercostal and your extracostal muscles, which are going to be used during increased ventilation, like with exercise, for example. And then we have another type of breathing called diaphragmatic breathing, which happens when that's your usual mode of breathing, when we're moving air in and out by relaxing the diaphragm and contracting the diaphragm in alternation to help change the lung volume, which changes the lung pressure. All right, so some of the things that we will be talking about are going to include the air volumes that are exchanged in ventilation, such as the tidal volumes, which is how much you're normally breathing in and breathing out. Your inspiratory reserve, which is how much you're able to breathe in at full capacity. Expiratory reserve, which is how much is left after you've exhaled everything that you can, right? That's your residual as well. And then also your minimal volumes. So most of what comes in, remember that's 500 tidal volume, only 350 of it is going to reach the alveoli because the other 150 is going to remain in the airways as dead spaces. If you could picture this as like a snorkel, for example, a certain amount of air is going to remain in the snorkel and not actually reach your lungs. And that's kind of the same thing that happens inside what we call anatomically dead spaces. All right. So let's talk about gas exchange. Gas exchange happens based on the concentration of gases on the inside relative to the outside. So the partial pressure of the gas is going to be the pressure exerted by that gas in the mixture. And if we, again, like everything else, it's going to go from high concentration to low concentration. So if we have a high concentration in one side, it's going to go to the other side. And the concentration of oxygen and carbon dioxide are going to vary whether you're looking at air that has just been inspired, which is atmospheric air basically, alveolar air, and air that is being expired or sent out of the lungs. Let's see. So internal respiration is going to occur inside the cells, and external respiration happens inside the lungs. Okay? So external respiration happens based on partial pressures of the outside versus the inside and the surface of gas exchange, which is going to be the total surface of all your alveoli combined, which is going to allow for diffusion across that alveolar capillary membrane. And additionally, it's going to depend on the solubility and the molecular weights of the gases, which is going to be above the purposes of this lecture. Now, we also have respiration inside the body, or internal respiration, that occurs in the tissues. And that's the exchange of gas between tissue blood capillaries and tissue cells, resulting in conversion of oxygenated blood into deoxygenated blood. Right. So, in oxygenated blood, most of the oxygen is carried in hemoglobin, and some is dissolved in the plasma. We talked about hemoglobin and how it's comprised of 4 atoms of iron. Each are able to interact with 1 molecule of oxygen. This is talking about factors that affect hemoglobin's affinity for oxygen. I went over that pretty extensively, and I'm not sure that's something that's talked about in the lab exam. Carbon dioxide is carried either in dissolved carbon dioxide, which is about 7% in your bloodstream, or mainly in bicarbonate ions as buffer or carbaminohemoglobin. So hemoglobin also has an affinity for carbon dioxide. But mainly it's going to be carried in the bicarbonate ions that are dissolved in your blood supply. All right, so there's a respiratory center in your brain, and it's the medullary rhythmicity area that is going to be responsible for controlling basic um, respiratory rhythm. Yeah, none of this is... I'm going to skip through all of the brain stuff. Well, okay, except for hypoxia. So hypoxia is going to happen if we end up with low oxygen, and we can have that happen for a couple of reasons. One, we can have it happen from anemia. So if we have a low amount of hemoglobin in the blood, we can't carry enough oxygen to the tissues. We can also have hypoxic hypoxia, which basically means that we have low blood oxygen because there is low oxygen, including things like high altitude or fluid in the lungs, etc. Stagnant hypoxia happens because the blood is unable to carry oxygen to the tissues. This happens during circulatory shock or during heart failure. And we can also have some sort of poisoning that can occur, like histotoxic hypoxia, where the blood's going to deliver the tissues oxygen, but the tissues can't use it because cyanide poisoning is an example. There are other factors that could happen. Basically, something's going to happen where the tissue is unable to utilize that oxygen properly. See, yeah, that's... We don't talk about development. We don't talk about aging. I'm not going to talk about infections. All right, so let's look at the images, because this is really what I would like you guys to focus on. All right, so this is showing you the trachea and how it splits into the bronchi. Here's that free-floating hyoid bone heading into the larynx, which is where our voice box is going to be located. Down that we have the trachea. The trachea has cartilages, so the tracheal cartilages are going to be rings, which eventually are going to split into the primary bronchi. We still have rings. Eventually we're going to lose those cartilage as we head down into the lobes of the lungs. This is showing you the left and the right lobes of the lungs. So remember, the right lobe has an extra fissure, that horizontal fissure. So they both have the oblique fissure, but the right lung has the middle fissure, which is going to give us superior and inferior as well as middle, as opposed to just superior and inferior, which is we find on the left. Also of note, the left is where we can find our cardiac notch, which is of course where our heart is going to be situated in the middle of our lungs. Okay. Additionally, if we look at this, here's the respiratory epithelium that's going to be on the inside. Here's our bronchioles, which are then going to split up and eventually going to get down into alveoli. The alveolar sacs, and the alveolar sac is going to be like a bunch of grapes, as opposed to alveoli are the individual grapes, right? And then we also have lymphatic tissue. We have capillary beds that are going to surround this whole thing so we can have gas exchange occurring. You also have elastic fibers around the alveoli that allow them to return, so they're going to be balloons and then come back down. So there's a lot of things to understand here if we're looking at a pulmonary lobule. All right, so that is going to take us through respiration. All right, so did we have... All right, buddy. Okay, we'll get that when we're done. We are finished. All right, so that's going to take us through everything that's going to be on this lab exam. So if you guys have any questions, now would be the time for you to go ahead and pop in and ask them. You can either do that in the chat, or you can do that by way of texting in the chat, or by just turning off your microphone and talking to me directly. Sorry. Oh, I see I do have questions in chat. All right. Oh, I apologize. Okay, I could not hear you, Julian. But you can go ahead and ask it now. Did you have a question, Julian? Did you want to ask? So I can see that you're unmuted, but I cannot see... Yeah, I can see you unmuted, but I cannot hear you. All right, well, if anybody has any questions, now's the time to go ahead and pop them in the chat. In the meanwhile, I'm going to go ahead and stop my recording so that